Okay, and for Gordon, yes, the horses they're not my horses, but this was when we were riding in Iceland. So this is a picture of Iceland and horses there.
It sounds like fun.
Yeah, it was. Okay. I'm Deb Kenny, and I really like this picture that I put on the front slide because ethics is very messy. And I'm finding that out more and more. And I just finished a 4-day conference with the American Society of Bioethics and Humanities. And some of the stuff that we heard there was just really incredible. And it made me more excited for ethics and bioethics even more. So I really am honored to be able to participate as a fellow with the DFEI program here at UCCS. What I'm going to be discussing today is the education of ethics and ethical principles with nursing students, both from the perspective of the nurses, the students, and of the faculty. I'm going to provide some recommendations for teaching and an explanation of the need to teach ethical principles to nursing students. And I will differentiate ethics principles from several different lenses, and then we'll make comparisons of them. And then, yes, there is going to be some participation here because I've got a couple of cases that we will discuss. So we'll just dive right in. So why do we need to teach ethics to nurses? Well, you know, nursing has been the most trusted profession every year since 2001. 2001, it was firemen, and I suppose you can probably all guess why. So anyways, this is a quote that was a study published in 1992. And it says, yet nursing graduates still lack adequate skills to be morally accountable practitioners. This creates a dilemma for the educator to find ways to integrate more ethics content into an already crowded curriculum. Now, this is a quote from an article written just this year about the pandemic and what nurses are encountering. There's no doubt that nurses are continuing to rise to the challenges of caring in this pandemic, but questions surround their ethics education and preparedness to be able to deal with public health emergencies on this scale. Now imagine for a moment you're working in an ICU in Colorado, and you've just had a surge of COVID-19 patients. You have 3 available ventilators, but you have 5 patients who need one. Do you know what to do? How will these be allocated? Do you know what the hospital, even know what the Colorado State Crisis Standard of Care Plan is? So this quote here is just another part of another study published. And here's the rub. While most nurses are highly ethical, only 22% can remember being taught how to deal with ethical issues in nursing school. They get out into practice and they encounter ethical dilemmas of different sorts, and they're not sure what to do. And by the way, this year we made it to the top again as the most trusted profession. So here's what faculty are saying. Most faculty will tell you that ethical principles are threaded through the curriculum, but it's really never discussed in any depth. Participants indicated in this study by Grayson that the marginalization of ethics content in a nursing curriculum occurs because it's considered less important. Therefore, it is pushed aside to make room for more core nursing content. One participant stated, it does take an effort on everyone's part to integrate it to keep the quality and the application of decision making. So what's the parallel between this quote and the one in 1992? Actually, not much has changed. Ethics are discussed insofar as what professional behavior looks like, but it's not discussed in depth, except maybe the nurses will get some philosophical background, for example, utilitarianism or deontology or feminism. The cases are almost never presented to nursing students. This is in part due to crammed curricula where faculty are trying to teach nursing students everything they can to get them ready to take and pass their board exams and to get them to at least a basic level of competence when they get out of school. So what to do? Well, these are some recommendations made by different faculty, along with some ideas of my own for teaching more to nursing students than basic ethical philosophies. Our representative nursing organization, the American Nurses Association, has a code of ethics that guides the conduct of the nurse, and I will discuss that more in depth in a bit. But it should be included, that code of ethics should be included at every level of nursing education, from those getting an associate's degree to those getting their doctorates. It should be discussed alongside ethical cases that these nurses may encounter. Consider the ventilator case I spoke about earlier. Undergraduates should be given toolkits and resources. If they know where to look, they'll find it. They could be given possible responses to typical ethical dilemmas they will see. For example, what to do if a patient is a no code, or beginning the end of life talks that providers need to have with every patient. Graduate nurses should take a deeper dive into ethical cases, things like organ donation, handling family differences of opinion, allocation of resources. I submit that this should be done as part of professional education, since many of these decisions do involve interprofessional teams. And what I'm going to do is I'm going to show you a short video right now regarding teaching ethics to nursing students and the importance, because Dr. Rushton, who actually is a friend of mine, says it best. She's a scholar at the Johns Hopkins Berman Institute of Bioethics and a Hastings Center Fellow. Okay, it's not playing. I'm not sure what the deal is here. It played this afternoon when I was, let's see what we can do here. There we go. Oh. Okay, it happens to be loading. Well, I just think we should hopefully, let's see here. Presentation. Tracy, you got any suggestions?
Unfortunately, videos sometimes don't seem to go well on Zoom, although sometimes they do.
Yeah.
Are you showing it from your screen? The PowerPoint, is that how you shared it?
Yep. Let me stop sharing and see what we can get.
And when you go in, make sure you do optimize for video and
okay. All right, well, you know what? It's not going to show, so I think we should just go ahead and move on. So at any rate, Dr. Rushton talks about the reasons why we need to teach ethics to nursing students. She talks about the fact that what I just said, the nurses have problems with ethical cases and they're not really sure what to do, especially beginning nurses. It's unfortunate because nurses find themselves in ethical dilemmas all the time, and especially now with COVID, the dilemmas that we're really talking about these days are inadequate PPE, which is personal protective equipment. So they don't have enough masks. The N95 masks that they were given, they had to reuse over and over again. And nurses, they're not sure what to do in these situations. The decisions for ventilators probably not going to be made by nurses, but they see it happening. And one of the things that Dr. Rushton does talk about is the fact that when they don't know what to do in ethical dilemmas and they see something done that really goes against their values, then nurses are at risk for moral injury. And so by teaching them how to handle ethical issues, we can sort of prevent some of that moral injury. Okay, yeah, it's not even going. So I'm just gonna move on here. So basically what we need to do is we need to teach the nurses how to answer questions. And what I've done is I've put up a little table here that shows.
You might want to share your screen again.
I don't know what's going on then. Okay, let's try this all over again. I'm not even seeing a share screen. Okay. You got it now? Okay. So I've put up a little tip. Can you all see my screen?
Yes, I can see it.
Okay, thank you. So basically, this is a little table, and what it does is it looks at different philosophical bents. Here you've got consequentialist, duty, and virtue. So let's go back to the question here. Basically, this is from different lenses for what a nurse might do. For example, okay, not. The nurse who looks at this from a consequentialist point of view, let's just say that there's not enough PPE. He is looking at the future effects of an action. For example, all those who will be directly involved or indirectly involved. So he doesn't have enough PPE, or the hospital doesn't have enough PPE. Is he going to not go to work because he is afraid that it's going to put his family at risk? And so he may look at it from that point of view and just not go to work. If he's looking at it from a duty or a Kantian point of view, he's going to look at duties that exist prior to the situation and determines his obligations. And so he would go to work because he has obligations to the patients, and his obligations to his family may not matter as much as the obligations to the parents. A person who looks at it from a virtue point of view, he might say, well, yes, I am a nurse. The nurse in me must come out. I must go to work because these are the virtues of being a nurse. Okay. I'm having a hard time switching slides here because I'm not sure what the heck is going on. Okay.
Oh, there you go. You see on the bottom there, there's actually controls too that you can go and look at the controls down on the bottom.
There actually isn't.
I can see them.
Okay. One possible framework that we could use for recognizing these issues, and let's go back to the ventilator. The ventilator example. For example, you've got 5 patients who need a ventilator and 3 ventilators available. So you recognize this is an ethical issue. Am I going to give the ventilator to the 65-year-old professor, or am I going to give the ventilator to a 35-year-old? Am I going to give it to an 18-year-old undocumented immigrant, or am I going to give it to a pregnant woman? So basically, it's recognizing this. You have to consider all the stakeholders. Who are the stakeholders here? Is it the nurse? Is it the hospital? You know, who's responsible and who has information, or who has a stake in this? You gather the relevant information. Okay, so this is just like going crazy. Then you got to consider the alternatives. What are the alternatives if I don't give it to that 18-year-old undocumented immigrant, but I give it instead to a pregnant woman or a child who has a disability? You formulate your actions and make a decision. The thing is that you've got to reflect. And when you make these kinds of decisions, you will reflect on your decision, you act on the decision, and then you reflect again. I found over the years that I've been involved in lots and lots of ethical dilemmas. And it's really only after I reflect on them that I can figure out, okay, what was the right thing? What did I do? What was the outcome of this? So I'm going to switch gears a little bit and talk about the ANA Code of Ethics. The ANA Code of Ethics basically has 9 provisions that guides the professional ethics every nurse must follow. It tells the nurse how to act, how to behave, what the professional obligations are, what their actions towards their patients are, that their primary responsibility is to the patients. And this and the professional code of standards of practice form a non-negotiable social contract for nursing behavior. The first code was actually established by the ANA in 1950, and the last revision was done in 2015. It started out with something like 17 provisions in 1950, and now it's down to the 9. The code it's really interesting because provision 5 of the Code of Ethics talks about how the nurse must regard themselves as an equal to the patient. So they take care of themselves in addition to their patients. And this is what I was talking about when I talked about the nurse who didn't have enough PPE and looks at it from a consequentialist point of view and probably doesn't go to work because he wants to take care of himself, because he doesn't want to put himself at risk. And the code allows for that. And what it does is it opens the door to conscientious objection, which is something that's kind of got taken a front seat lately. And nurses do have the right to object conscientiously to certain types of care. The code does not ever specify the philosophical underpinnings, nor does it describe underlying principles, but it describes the duties and the obligations, i.e. the deontologic principles underlying the code. Now, I'm going to talk a little bit about the medical bioethical principles. This is kind of interesting because it is principalism at its best. So back in 1980, Beecham and Childress, when they wrote their first book on medical bioethics, they described these 4 principles: beneficence, which is do good; autonomy, which is the patient has the right to have a say in their care; non-maleficence, which is do no harm; and justice, which would be every patient has a shot at the ventilator. Most of you will recognize these as the principles that the IRB uses to judge research or research bioethics. So, but this is actually medical. Beecham and Childress just finished another book a few years ago. They updated their book. And what they did was they included much more justice in their book because it's taken a front seat where we have inequities of justice in ethics. And it's really taken a front seat in the COVID pandemic because we have the COVID has really exacerbated inequities in healthcare. Now, these are the DFEI principles, and they are integrity, trust, accountability, transparency, fairness, respect, rule of law, and viability. And what you'll see with these is they actually kind of line up pretty well with the other principles of the ANA code and the biomedical ethical principles. And so what I did was I created a little chart here to show you kind of how these do line up. So you have the DFEI principle of integrity, and in the ANA code, they talk about the integrity of the profession. In the medical bioethics, beneficence or do good, have integrity would line up with that. And you can see how I've lined them up across the board. For example, fairness in the DFEI principle would align with the social justice or provision 9 in the ANA Code of Ethics and the justice in the biomedical ethical principles. So the project that I'm going to do is basically I have an opportunity to teach ethics with DNP students in my leadership and organizational systems class. And you can see I've got 10 students for this fall, and we're going to start this in week 11, and it's now week 9. And I will be teaching them, and I'll tell you how I'm going to do it here in just a sec. And then in the spring, I have projected 10 to 15 students. Fortunately, this course, because of a change in curriculum, we were able to offer it twice this year. And so I had the opportunity to double the number of students that I was going to be teaching. The bad thing is I only have 2 weeks to do it. I'd love to do a whole course, but our curriculum at this point in time is not allowing that. So what I'm going to do is I'm going to create lectures on similar to what I'm doing today on the different ethical principles, only a deeper dive into it. We do have, because it's an online course, I will have live discussions via Zoom, although I can't make them mandatory. But I will tell you that most of my students do attend the live lectures that I do with them. We will have readings and videos of cases. We will have asynchronous discussions of actual cases. And then they have to do a writing assignment, and they have to do an expository essay arguing for the necessity or not, depending on what they want to choose, of ethical leadership principles in that they've learned. And so this is how we're going to conduct these 2 weeks of learning. And I'm going to try and cram in as much as I can, but no promises there since it's only 2 weeks, but we'll do the very best we can. So nurses are pretty obsessed with outcomes because we do it all the time in hospitals. So what do I hope to achieve? Well, I want to give them the knowledge of ethical principles, comparing the 3 different philosophies of the ANA Code of Ethics, Biomedical Ethics, and the DFEI Principles, as I will include those in there. And then basically, though, I'm not going to be able to measure these directly, except I will be able to see how they argue for ethical leadership in their expository essays. I expect they'll be able to, with guidance, discuss complex ethical issues in their asynchronous discussions. And since they work in interdisciplinary teams, they're going to be able to convey those convictions to other providers. So I'm hoping that, and one of the ways that I intend to do this, because I find it very interesting. And one of the things that I'm learning from my own bioethics classes that I'm taking this semester is there are lots and lots of ethical cases and ethical lessons to be learned from television, films, and films. And so I have detailed a number of videos that they will watch, and then we'll talk about the ethical issues. Now, doesn't look like I'm going to be able to show you these films. So what I'm going to do then is just, we're going to talk through, I'm going to tell you what went on here. And then this is where you get to have some discussion, okay? So in this film, this is a short film, and this physician, I don't have a name, but anyways, the guy standing there with the chart, he goes in and he picks up this chart, and the nurse practitioner comes in and says, "Oh, hi, I didn't know that Mrs. Smith was your patient." And the doctor says, "Well, she's not really, but she's my wife's golfing partner, and she didn't tee up this week, and I saw that she was being seen here, and so I thought I'd find out how she was doing so I could give an update to my wife, who would be happy to receive it." And the nurse practitioner says, "Oh, I didn't know she was your patient." And the doc, he sticks out his chest and he says, "Well, she's not really, and she might be, but she's not right now." And then he takes his glasses off and he says, "Do you have a problem with that?" And that's the end of the film. So what I'd like to do now with this is to have a discussion of some of the ethical issues that might be inherent in case number 1. So if anybody has anything they'd like to say or talk about, this is the time.
Hey, Deb, it's Dan Likens. It seems like in this case, the physician is really putting his nose where it doesn't belong, and there's certain privacy rights and expectations a person should have. And it looks to me like the physician is violating that because he has a personal interest in this person rather than a professional interest. So he's not being a professional in this regard. He's acting on his own personal desire for information that he has a right to.
Okay, so what rights is he violating?
I'd say he's violating the patient's expected right to privacy, commonly known as HIPAA.
Anybody else have any thoughts about this?
Yeah, this is Alex Blerde. I work in a surgery center. I'm getting my MBA in healthcare administration here at UCCS, and I frequently see doctors flaunt the rules like this. My father's a doctor, so I know how some of them can think that they're holier than thou sometimes. And I frequently run into situations where doctors will leave patient files out in the open, and will frequently try to butt in where they're not expected. And so this is something that, right, for me as a young career professional, has been very hard to push back on, but something that the nurses, particularly the young nurses, are very hesitant to speak out on where I work.
Alex, you're exactly right. I wouldn't think that a new graduate nurse or nurse without much experience would want to push back to the docs. I can tell you that I've found myself in this position a number of times. What do you think that this nurse practitioner should do in this case?
I would refuse. I mean, there's a difference between what she should do, and I think also we have to take into account what is realistic, because I know for so many nurses that I work with, the idea of pushing back against a doctor who has so much more weight and say in what goes on in our surgery center and in hospitals generally. My mother's a nurse. She has pushed back against doctors, although she has very little filter. And, it's gotten her in trouble in the past. And so I think, if we're looking at it from a moral standpoint, absolutely stand up and say, no, you're against the law. This is not your right. This is not your patient. You're going against HIPAA. The problem is doctors don't like that. And depending on how the way the surgery center or the hospital management works, it could come back to bite her.
Exactly. I have pushed back against docs, and I've gotten myself in trouble. But then other times the docs have said, yeah, you're right, I'm sorry, and they'll put the chart down. So I think in this case, the nurse would point out to the doctor that this is not the right thing to do, and be able to provide some rationale as to why this isn't right. Yeah, some docs will push back. Some docs will push back. Okay, the next, yeah.
Well, I'll also throw out, this is where sort of like the giving voice to values approach comes in handy. It's easy to sit here and say what the right thing is to do. It's pretty obvious. It's quite another to actually do that. So one thing you can do as a nurse is practice and script out a response and practice it. Like, do a scenario, have somebody play the role of the doctor and pull rank on you or whatever. And I mean, it's easy for us to sit here and say what we would do. A lot harder if you're a brand new nurse and there's some doctor who's been there for 30 years. So you have to practice, you have to script. I think the real dilemma here is doing something. You can make the decision, but then doing something about it is the hard part.
Absolutely. Absolutely. Yeah. I found myself face to face with a doctor at one point in time who was kind of reaming me out about something. And I said, I just looked at, and the nurse, he had called the nursing supervisor down. And the nursing supervisor is standing in the room. And the minute I said, how dare you talk to me like that? The nursing supervisor backed up against the wall. And she's like, how dare you talk to him like that? And I said, if this is the way it's going to be at this hospital, then I might have to quit.
There you go.
I ultimately did. So let's go to the next slide. Okay, this one is a great one, and it's apparently not going to work for us. Let's see here. It's just gonna. So this actually is a scene from the movie Wit, where Emma Thompson played a professor that had developed a cancer, and she was terminal. And the young man on the left-hand side of the screen, he's the physician, and the nurse is the woman on the right-hand side of the screen. Now, the way this starts out is the doctor just kind of goes into the room, and he's looking at the chart, and he's clicking his pen. He was kind of an arrogant resident is what he was. He's clicking his pen, and he looks at her and he says, "Professor Baring, how are you doing today?" And of course, no response. And he looks at the chart and he says, "Yeah, 2,000 in, 30 out." And he clicks his pen. He says, "Your kidneys are shot." And then he says, "Professor Baring," and she doesn't respond. He writes down on his chart, "unresponsive." And then he puts his chart down on the bed, and he goes to check her pulse, and there is no pulse. So what happens is he calls a code. And so he starts doing CPR on her. He pulls her gown down, and you see the whole front of her exposed, and he's bouncing her around the bed. And the nurse comes in and says, and screams at the doctor, and actually throws him on the ground and says, "He's a no code. You saw Kolikian write the order yesterday. You know better." And then the code team comes in, and they start doing they start coding her, and starting to innovate and starting to shock her. And the resident is kind of sitting on the ground, and he's like, no, she's a no code, she's a no code. And they're telling him to get out of the way. They're telling her to get out of the way. And she's screaming, "He's a no code, she's a no code." And finally the resident says, he yells, "I made a mistake, okay?" And the code team says, "Let me see the chart." And it shows the no code order, and they're pulling all their equipment away. And so the nurse, she pulls up the bed cover so that the patient is no longer exposed. And the doctor wants to come in and help her. And this is the scene where she's putting her hands out, "Just leave her alone, leave her alone." So he walks out of the room. So my question is what do you think the doctor was thinking here?
I think, and this happens in reality all the time, our boundaries get lost a little bit when we have a relationship with a patient that's outside of she was a colleague. If she was a colleague, then he wasn't thinking. So I don't think, it doesn't sound like it was an intentional thing, but just losing the perspective and wanting to do everything, but not kind of going through your professional boundaries.
Okay. What do you think the nurse was thinking in this whole scenario?
Deb, Carol Traylor here. I think that the nurse was trying to protect the rights of the patient. The fact that, she'd already been named a no code to step in and protect her patient from an intervention that was not necessary and was uncalled for.
Okay. And what about the code team? When they were busy doing this code and the resident screams, "I made a mistake, okay?"
I think that's a lot for a resident to admit in front of professional colleagues.
Mm-hmm.
I think it would have been really easy for him to just let the code team go ahead and complete running the code. And if they revived her, that would have been a bad outcome. And if they hadn't, then he would look better in their eyes as far as calling the code initially.
Okay. So what's going on in your heads now with this whole situation? What are you thinking about?
Yeah, this is Lieutenant Dan. I'm thinking it's really interesting that to get the attention of the code team, he had to make a personal appeal. He had to identify himself personally. I have made a mistake. And that wakes them up out of this. We should, we're just following procedures. The code's been called. We got to do what we're told to do. Even though these two people are sitting here, obviously looking rather much like you shouldn't be doing this. So it's just, it's intriguing. That human level is what gets their attention.
Yes. Okay. I can tell you that I've actually been in this situation. There was a time when we had a patient who I had been making an appeal all morning for him to be moved to the ICU because they had just done an echocardiogram and found a big clot in his right atrium. And one of the nurses came to me and said, I think the patient's going south. And this was in a regular med-surg ward. And so we go in and we're doing and I said to one of the nurses, go down the hall and get the residents out of their morning meeting. And we were trying to get a pulse ox on this patient, and we could not because the patient had no peripheral pulse. What had happened was the clot had moved into the lungs. And so the patient really had no pulse, and we could not get a pulse ox. And the resident actually came in and put the pulse ox on the patient because the patient still had a heartbeat, and said, oh, it's just not working, and threw it at me. And then I said to the other nurse, I said, go get the code cart right now. And the patient ended up coding, and the patient ended up dying. In the heat of the moment, it was really, really hard for me not to get mad at that resident because she had thrown a machine at me. And back then, pulse ox weren't these little things that you put on somebody's finger. It was a whole machine. We all knew the outcome was what it was going to be. It was only on reflection, alone in my office, that I was able to process it all. We never did come to a resolution, the resident and the attending and the 3 nurses that were involved. But what all this reflection did was it better equipped me to deal with ethical issues in the future. And thinking about all the complexities of that case, plus this case here in front of us, how do we expect newer nurses to know this stuff? I'm asking you a question. Anybody can chime in.
Deb, it's Carol again. I think that those of us that teach in nursing education have a responsibility to prepare nurses for different scenarios like this, then to encourage these students to kind of think through the process themselves and what they would do if they were in that situation, to role play, so that they feel more equipped when they're actually faced with that kind of dilemma in a clinical setting, that they can reflect on what did I do when we practiced this, and how can I adapt that to this current situation?
Exactly. So yeah, we can't expect newer nurses to know this kind of stuff because this is the kind of thing that comes with experience. What I didn't show in this film, an earlier scene of this film shows Nurse Susie, which is the nurse there, sitting with the patient and sharing a popsicle and talking about what her wishes are for dying, and that the patient at that time was responsive, and they were just sitting and talking about expectations, and Susie being honest and transparent with the patient, saying, they knew they couldn't cure you from the beginning, and the patient saying, why are they even asking? Why are they giving me all this chemo when they know they can't cure it? It was a very moving, and if you haven't seen the movie Wit, I would encourage you to watch it. So at any rate, there's lots of lessons to be learned from this film and from other films. I've seen some really heavy ethical issues in the TV series House, some kind of funny ones in the TV series MASH. I think all of these films could be used to help these nurses and talk them through these kinds of cases, because even though TV kind of sensationalizes them, it also shows what patients expect from watching these kinds of shows. But I like the film cases because they're safe, and I think they're more realistic than, honestly, I think they're more realistic than any simulation we can put together. And it can teach the nurses how to process some of this before they get there, because they will find themselves in these kinds of situations. And so, back to the very beginning of when I started talking, I said, it's really important for nurses to learn these kinds of things, but they're not being taught these kinds of things because their curriculum is already so jam-packed full of stuff. So with that, I'd like to ask if there are any questions.
Yeah, it's Lieutenant Dan again. I got a question for you.
Sure enough.
I have an idea. I don't know if you think this would work, but it's worked for me really pretty well over, gosh, a long time now. Because I guess I've been living here for 20 years. So it's been about 18 years. I taught at the U.S. Air Force Academy. And during our initial orientation for the cohort of instructors, the year I went in, the superintendent was a 3-star general named J.D. Gallagher. He's an old fighter pilot guy. And he put us in his room, and he stood up in front of us and he said, hey, look, for all you military guys, and I was one of them, he said, I want you to know that I could replace you with a civilian instructor who would cost a lot less. But Congress has allocated the money to have me bring you here because they think that you bring something different than the civilians. And we're all kind of thrown back in our chairs going, he just said he could fire us and replace us for cheaper folks, but he's quite happy, and Congress is quite happy to have us here, even though we're more expensive. So our ears were turned on at that point, and he said something that has affected my teaching from there on out. He said, you guys have field experience, and I expect you to share that field experience with the students every day that you're in class. And I don't know, I never talked to any of the other folks and asked them how many of them did it, but I adopted a system that I use. I call it life lessons. And so I literally start every single lesson with a life lesson. It's got to take less than 2 minutes. It's better if it's less than 1, but to open up a conversation and share the nuggets of wisdom that I have seen along many, I guess it's decades now. And I routinely have students tell me that that's what they remember going forward from the course the most are the life lessons. And the more succinct you can make them, the better, the more people will listen, because a lot of them want to hear the content and they know they've got a test come and they get all antsy about that. But the real value for the students comes in the life lessons from my perspective. And it's, for me as an instructor, it's very fulfilling just because I get to share what I've learned. And I've had a fairly diverse career, flying, teaching, civilian, military, and all over the world doing different things. So I get to share the real nuggets that I want to pass on by doing that technique. And I just wonder if that would work for you and others in the nursing school. Carve out 1 minute or 2 minutes, and never more than 2 minutes. Oh my gosh, you will get such negative critiques. But yeah, it's a way to open conversations, get students thinking about these things. But as I listen to you, your stories are engaging. You have the firsthand experience that the new nurses need to have, and you've got to find a way to transfer that to them in a crowded curriculum like I have.
Okay, so the person from Western, you've unmuted. Did you have something to add?
Yeah, well, very interesting. Obviously, I'm not in your field, so some of the terminology and the problems are foreign to me. But I just wonder, have a parallel in accounting. We only saw a change to introduce ethics courses in the curriculum when the board of examiners for the CPA exam required those extra courses. And I just wonder how that works then for nurses. I mean, you talked about the board exams. If they're not requiring any kind of ethical or test of ethics, how can you ask the nurses to study it? Because at one point, as you said, they have such a cramped curriculum, and just put another extra thing on their back without having an irrelevance that the system or that the board puts on it.
Mm-hmm. You know, I think part of my philosophy of teaching, and I've been teaching for a while in different venues, if you will. And yes, I'm retired military as well, so I have that experience behind me. But if you teach it, it's kind of like if you just give them the stuff that they're going to regurgitate and forget, then if you give them ethics like it's something they have to regurgitate and forget, then they will forget it. But if you teach it like Dan was saying, with life experiences, reach out to them on a personal level, teach them how to think through different scenarios that they can use that thinking for other scenarios. And I think you're going to get, on the long run, better nurses. And you're going to end up with nurses who, for example, in the COVID, you know, we're talking a lot these days about moral injury, because nurses are expected to come to work. They're expected to work with inadequate PPE. They're expected to take a higher, heavier patient load. And they're seeing things being done in the hospitals that are not normally done, and it goes against their values. And so it creates this moral distress for them. But I think if you teach them how to think through scenarios, you're going to end up with better and stronger nurses. And that's just my opinion. Debbie, I'd love to hear yours. Are you still there, Debbie Pollard? Yes, you're still there. I'd love to hear your opinion as the department chair.
I'm sorry, Deb. I was just on a phone call with somebody.
Oh, I'm sorry. We were just talking about life, giving the nurses life experiences rather than stuff that they just regurgitate and forget.
Absolutely. You know, in nursing curriculum, you know, we've always been too content laden and trying to teach them all the content. And students love, and we see this repeatedly from students in their evaluations, they love faculty who do provide the narrative pedagogy, the stories, like Dan was talking about, the lessons learned, the life lessons, and they learn so much from that. And you hear it all the time in course evaluations. I see it all the time in the FCQs, that students do retain that. That's something they connect with, are those life stories for sure.
Yeah. Yeah.
And I think these are difficult conversations. And I think as faculty, we have to continue to be putting more emphasis on planning for students to practice these difficult discussions. Because most students, you know, this is a low volume but high risk area. You know, fortunately, every student may not see it in practice, unfortunately, to actually get the experience. But I think providing it in some way, whether it's through simulation, whether it's through class discussions, role playing, whatever the strategy, is providing them that practice, that toolbox. It's a part of their toolbox for these difficult conversations that will come up eventually.
Thank you.
if I can just jump in, I'm not saying that regurgitating and recall learning is the best. What I'm saying is if the nurse doesn't see that the system, there's no systematic appreciation for learning it, then why do it? Because when they go then and face the doctors who, like, well, as my nurse mother always said, the gods in white would tell them what to do. The problem is that there is no systematic support for them. And that's why I compared it to accounting. A lot of students didn't want to deal with it, but suddenly it was required by the board that they had to deal with it. Some never learned, some learned great lessons and they took them with them to the industry. But finally, the whole system of the accountants took that issue on and said, everybody has to at least be exposed to this. And whether it hopefully does any good, we cannot ultimately influence that, but at least we force the students that they have to look at ethics as part of getting a CPA license. That's where I say, I'm not talking about the style of teaching them. I agree with you that life stories and narratives are more effective, but I'm just saying if the system doesn't push it, how can you convince them that it's necessary and needed?
Mm-hmm. I agree with you. I agree with you. It's been a kind of a lively hour, and I'm so sorry I couldn't show you the films. They were pretty meaningful, but I think we were able to get through that nevertheless. And Tracy, I'm going to hand it back to you.
Yeah, I wanted to comment a little bit on your case examples. I thought they were perfect. Because I know that Michael has also looked into the giving voice to values approach. And what Mary Gentile has done is identified that, yeah, you might know that doctor is wrong by taking that file and shouldn't be doing it. But as you said, it's hard for them to speak up or how to have the doctor realize I shouldn't be looking at this file or I shouldn't be acting this way. And the giving voice to values approach allows the students to actually practice responses or have techniques to perhaps reframe it or ask a question. Your example where she kept saying, well, is that your patient? It's almost making it so that the doctor can all of a sudden realize, oh, I shouldn't do that. So if I could ask you to stop sharing your screen, and we'll finish up for today. It's a little bit after 3. I understand some people had some issues getting on to the roundtable, the Zoom, and I really apologize for that. Hopefully we'll be able to fix that in the future. With that, I do want to close and say thank you to everyone for participating. We will have the recording available as well as the PowerPoint, which could include those videos that you couldn't see, as long as Deb agrees.